In this video, we will present a complex upper extremity deep venous thrombosis thrombectomy. The first thing we will do in the video is discuss the presentation of an upper extremity deep venous thrombosis, also known as a DVT, discuss treatment options and considerations for these types of patients, walk through the specific treatment that we chose for this patient, and then discuss the follow-up. This was a 30-year-old man who presented with a history of recurrent deep venous thrombosis and pulmonary embolism who had a known hypercoagulable state. He had a history of an IVC filter placed 5 years prior, as well as had been off of his anticoagulation for various other medical conditions for the past 6 months. The patient reported a 3-day history of right arm heaviness and fatigue. He had a PICC line that had been placed for antibiotics 7 days prior to presentation for a non-healing wound. Subsequently, over the last 24 hours prior to presentation, he had a significant increase in his right arm heaviness and fatigue and decided to come to the emergency room. On exam in the emergency room, the patient had a severely swollen right arm as well as an intact PICC line in the right arm. He had normal pulses and a normal motor sensory exam, other than he had some limitations of his movement secondary to the edema in his arm. An ultrasound in the emergency department demonstrated a subclavian, axillary, and brachial vein DVT. The patient was fully anticoagulated by the emergency room, and the vascular surgery team at Houston Methodist was asked to evaluate the patient for further management. So the first thing that we did, as we do with all patients, is determine what are the risks with this patient, what is the natural history of this pathology. The two big things that we worry about with deep venous thrombosis are pulmonary embolism and post-thrombotic syndrome. With pulmonary embolism, specifically for this patient, we do know that there is a lower risk of embolization from the upper extremity, certainly when compared to the lower extremity. We also know that that risk is remarkably reduced if the patient can be adequately anticoagulated. Because this patient could be adequately anticoagulated and he didn't have any contraindications to anticoagulation, we felt that this was of small but not zero risk in terms of his pulmonary embolism risk. On the other hand, his post-thrombotic risk was quite significant. We do know that from a literature perspective, about 60% of upper extremity DVTs will go on to develop some amount of post-thrombotic syndrome. But this can be quite varied in terms of how much this impacts different patients. In this patient in particular, though, this is a relatively highly morbid condition given his young age of 30, as well as this being his dominant arm. So if we're going to potentially intervene on this patient, there are certain things that we have to prepare for, especially in this specific patient. This is a right upper extremity deep venous thrombosis. The patient has an existing IVC filter. I'm expecting to find some amount of acute as well as chronic thrombus because of his history of prior DVT and pulmonary embolism. And then with any upper extremity DVT, I'm worried about there being issues with the costoclavicular junction, whether it be occlusion or stenosis from the clavicle or the first rib. Really important things to also consider is what is in the available toolkit. Things like where can we access the different blood vessels that we need to? What are other thrombectomy devices that are available? What are their adjuncts? What might we need? From an access point consideration, there were 4 that really should be considered in this type of patient: the right brachial vein, the right arm PICC line that was in place already, the right internal jugular vein, and the right common femoral vein. These each have different advantages and disadvantages when treating different types of upper extremity deep venous thrombosis, and we'll discuss how we decided to pick what we used in this situation. Our thrombectomy devices that we have on hand for these types of situations: we have aspiration catheters, the FlowTriever from Inari Medical, the Indigo from Penumbra, as well as the ClotTriever from Inari Medical. Other things that we typically have as adjuncts: intravascular ultrasound, also known as IVUS, balloons, stents, and of course surgery, predominantly first rib resection. It is really, really important to have a plan as well as several backup plans when tackling the more complicated of deep venous thromboses. First off, you're going to always have better outcomes if you have these things planned out ahead. You're going to drastically reduce the amount of time that patients are under anesthesia. You're going to reduce your radiation and contrast use during the surgery. And you're going to overall decrease your resource utilization, both in terms of time as well as money. So in this case, my plan was to cross and protect the IVC filter so that our intravascular devices would not have any issues with the filter. Plan to do a ClotTriever thrombectomy and then use IVUS and possibly angioplasty to deal with any costoclavicular issues that we ran into. The choice of clot-triever is primarily because this was considered to be an acute on top of a chronic pattern, most likely, and a clot-triever, in our opinion, would allow us to access that chronic thrombus as effectively as possible in our first attempt. If we were unable to protect the IVC filter, we would likely then go to our backup plan, which would be aspiration thrombectomy, coming from both above and below the thrombus from two different access points. Before we go to the operating room, I like to always supply the operating room team as well as the anesthesia team with some basic information, typically in written form, so that things can be prepared as quickly as possible for us. In this case, the information that we provided was that we would like the patient in the supine position with the right arm extended to allow for right arm and bilateral femoral exposure. We requested general anesthesia. This procedure could be performed under local anesthetic with or without monitored anesthesia care. However, given that this is potentially uncomfortable and the need for relatively high-end imaging, the decision was made that general anesthesia would be the most comfortable for a relatively low-risk patient for anesthesia. The estimated case length was 45 minutes. The equipment that we asked to be available, we would like to do this in a hybrid operating room or at least with fixed imaging available, ultrasound at bedside, the thrombectomy cart, which has all of our different tools and instruments and adjuncts, as well as the intravascular ultrasound. What that looks like is this. This first area here that you can see in the middle is the patient prepped supine on the bed with their right arm extended out at 90 degrees. You can see an accessory table here on the patient's right side that allows for easy access to the devices that are in the right arm. I'm 5'7". I like to have my main working monitor directly in front of me at eye level across. And in the negative space here, you can see where our accessory monitor would exist. So that way that we don't have to turn to see the monitors as we are working, either when facing the patient or facing the patient's right arm. We elected to begin the procedure by placing an 018 wire through our existing PICC line, and then over this placing a burn catheter. Through the burn catheter, an 035 wire could be then placed below the IVC filter, and a 9 French sheath could be placed so that a venogram could be obtained. You'll notice in the blue area on the screen, there's extensive collateralization throughout the venous system in the right arm, indicating a more chronic process than one might think given the symptoms that the patient had. We then got to work placing our access in the right common femoral vein. Here you can see us trying to place a 16 French sheath through the filter to allow for the passage of devices and wires from above safely below the filter without interacting with it. Once the 16 French sheath is in place, we then pass a floppy wire from below and place our snare from above. We expand our snare and then attempt to cannulate the snare using our floppy wire. Once the wire looks like it is through one of the loops of the snare, we then grasp it with the snare and externalize it through our arm access. Once the wire is externalized, you can see on the right side of the screen that the wire is grasped with a hemostat to not allow it to move. And this allows for the right arm to be exposed with whatever devices and sheaths that we need in order to accomplish what we need to do. We then confirm our placement of everything with another venogram, and we're ready to get started with the thrombectomy. Here you can see our clot-triever device passing through the veins over our wire. Very important, you will then notice that our camera then comes further down into the abdomen to allow us to watch our clot-triever device actually pass below our IVC filter under direct visualization. Very important so that it does not get snagged there. You can then see us pulling our clot-triever back to allow for thrombectomy of the veins. We then repeat this process several times in different orientations to allow us to remove any and all of the chronic as well as acute thrombus that might be anywhere from the costoclavicular junction out to the arm. We then reposition our camera to be able to take another venogram to see the effect of our thrombectomy. And you can see several different changes. First, very, very happy in the blue area here. You can see that there is an absence of collaterals that were previously there on the previous venogram. However, in the orange area more centrally, you can see that there are still abundant collaterals in the neck area, as well as what appears to be some thrombus still at the costoclavicular junction. We therefore passed our clot retriever one more time, again, very carefully passing the tip of the catheter all the way below our filter, as demonstrated here. And then as we retract our clot retriever catheter, you'll see that there's very high degree of intention with the orientation here in the blue box, and then a brief pause to allow the nitinol to fully expand into the chronic thrombus, and then further retraction of the catheter to allow for retrieval of any residual thrombus right over the first rib there. Another venogram demonstrates some improvement of that, still some collaterals above the collarbone, but significant improvement with much more contrast rapidly filling the right atrium. We then post-dilated this area with a balloon. You'll see us inflating our balloon just distal to where our worst part is at the costoclavicular junction. And as the balloon is deflated, it is pulled back, and you can see a very nice outline of the first rib with the clavicle on top of it. After this, the balloon is deflated and then removed. After our balloon has been removed, a venogram is performed through our sheath in the arm. This demonstrates significantly better flow through all of the veins in the arm and ending in the right atrium. At this point, we elected to terminate the procedure, and we removed our sheaths as well as our devices from each of our access points. The total procedure took 43 minutes. We had the patient rest for 2 hours without moving afterwards because of our groin access site, and the patient was then discharged home the following day with an Eliquis prescription and a standard clinic follow-up in 3 weeks in our venous thromboembolism clinic. The patient reported immediate symptom relief with a significant reduction in pain and edema in his right arm on the first postoperative day. The patient was then seen in the venous thromboembolism clinic at 3 weeks and then followed up 6 months later without any symptoms. This is a patient that's very high risk for recurrence of their DVT and pulmonary embolism, with both a history of pulmonary embolism and DVT, as well as being hypercoagulable. We therefore emphasize the importance of continued anticoagulation, likely lifelong, for this patient. We also discussed the potential need for first rib resection and future stenting of these areas with the patient, although hopefully those will be unnecessary.